Finished training for the day? Time to fight post-workout fatigue with Core Power Protein Shakes. They're packed with 26 grams of high-quality protein to build muscle and electrolytes to help hydrate. The nutrition you need to help your body replenish, rebuild, and repair post-workout so you can power on to the next one. Champion your recovery with Core Power. Visit corepower.com to learn more.
Introducing Meta Ray-Ban Display, the world's most advanced AI glasses. With a full color display built into the lens of the glasses, it's there when you need it and gone when you don't. Send and receive messages, translate or caption live conversations, collaborate with Meta AI, and more. Be one of the first to try Meta Ray-Ban Display. Visit meta.com/Meta Ray-Ban Display to book a demo and find your pair.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya del Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing a new to us treatment for alcohol use disorder.
Are we intoxicated with fatigue tonight?
You started just laughing when you told me to look alive. I feel like I was talking. I feel like that's like my mom would say before I go into church. Look alive.
That's a good vibe. I could be happy with that vibe. No, it's way past what we call it geezer midnight. 9 p.m. is old geezer midnight, and it's way past 9 p.m. right now.
Yeah, and our other thing. Our favorite term is the old person all-nighter.
Yeah.
Go to bed at 10 and wake up at 4.
Right. To do your all-nighter. Exactly.
So what's going on in your world? Anything exciting?
Oh, my world is very calm, but I did have some addiction medicine news I wanted to share. I hate, I don't know. I don't want to be an old codger talking about geezers, but I started to feel more and more negative about medical cannabis, medical marijuana. So there was an article in the Annals of Internal Medicine, which is my big journal that I like, from July about medical marijuana. And our listeners know that you and I are both a little bit skeptical of the medical claims. And this article was about medical marijuana use in Pennsylvania. So in Pennsylvania, anxiety was not originally included as a qualifying condition for medical marijuana. You could get it for chronic pain, but not for anxiety. It was added later. And so the authors looked at which conditions were used as qualifying conditions for medical marijuana before and after the addition of anxiety to the list, which was super interesting. So before anxiety was included, the most common qualifying condition in Pennsylvania was chronic pain, which accounted for 67% of the medical marijuana certifications prior to when anxiety was introduced. So most people were saying chronic pain was why they needed medical marijuana. Once anxiety was introduced about 18 months into our state's program, the number of patients with certifications for anxiety immediately exceeded those for chronic pain, eventually becoming 60% of all certifying conditions. And the number of people getting certified for chronic pain did not decrease. This was a whole new set of additional people getting certified for anxiety. So it just immediately anxiety was the reason that the majority of people said they needed medical marijuana. And since November of 2017, in Pennsylvania, 1,730,600 medical cannabis certifications have been issued. Almost 1 million of them for anxiety. So Pennsylvania has about 13 million people. So 13 million people and 1.7 million certifications for medical marijuana. So one certification for about every 7.6 people. Now, I will say that some people get multiple certifications because it needs to get renewed. So it's not necessarily 1.7 million people. And some people are certified and aren't using it, of course. But still, that's a lot. So 1 in 5 American adults has anxiety or an anxiety disorder, so pretty high prevalence. And 1 in 8 Americans takes an SSRI. So that just puts those numbers in a little bit of context. So there's still way more SSRI use than medical marijuana use. So I don't really know what to make of these high numbers other than to just say this is a lot for a quote unquote medical intervention that has not been rigorously studied, has not been FDA approved, and has significant negative health impacts, both pulmonary and cardiovascular, and on balance worsens mental health outcomes. So again, just yesterday, this major review article in the Annals of Internal Medicine was published that showed high concentration THC products are associated with poor mental health outcomes. So this is something that worsens mental health. And yet, like, just millions of people are taking it for quote unquote anxiety, which of course I don't know. I don't want to say they're not. I don't want to invalidate anyone's experience, but like, I don't know. What do you think, John, of all this medical cannabis data in our fine state of Pennsylvania?
Here.
Mm-hmm.
Like a legalized marijuana for recreational use is here. You can say it's not, but it's just a slow bleed, right? One state by one state by one state. It's like casinos and gambling, right? We had the same thing when I was a kid, and now everyone has gambling because of the financial ramifications, because people want it. I actually kind of personally wish it was just legalized and we could have an honest conversation about it, because I think at this point, people that want it are going to get it. And I think this illusion that, it's all for medicinal purposes and it's natural, it prevents the real conversation, which is like how to mitigate the harmful effects of it with long-term use if you already use it, like alcohol.
Right. Admitting that it's a pleasurable thing that people like, it gives people pleasure, they want to use it. It has some downsides, and we should discuss it honestly, but like calling it medical is kind of embarrassing from a medical community standpoint.
It's like when it's like medicinal wine, right? When people are like, oh, my 2 glasses of wine, it's my medicine, right? It's not like that. We finally stopped that nonsense, right? And then we have an honest conversation about it, that it's a carcinogen, and in low doses, it's harm mitigation, it's fine. The higher it is, you use it, the worse.
Yeah. Well, yeah, that's what I was thinking. And people do
I have to do like one more visit for like an adult that thinks they have ADHD that smoked marijuana in the car before the appointment because they smoked marijuana all day and don't understand why their attention span isn't good anymore. I feel like that's like a new visit I get once a week.
You should write up an epic template for that.
It's like the room smells of marijuana because they're smoking marijuana all day for their medicinal purposes, and then they now think that they have adult ADHD.
Yeah. Well, that's the thing that's hard for me is like, I know plenty of people who use marijuana without harm. They enjoy it and that's fine as part of their lives. But so many of my patients who are suffering from substance use disorder and real serious life dysfunction, then they're smoking marijuana like really every day. It's just not helping them. It's hurting their health. It's taking away their money. It's sapping their motivation, making them unable to kind of meet their goals. It's not helping.
Not even every day though, right? So like people like drink every day, and that's not a good habit. But like people using this for their medicinal anxiety, right? They're not just doing it every day. They're doing it like all day, every day.
Right. Every hour.
I mean, it's even like they're doing that throughout the day. It's like they're living their life under the influence of the substance. And I think it's a wolf in sheep's clothing, it's a wolf in sheep's clothing in many regards.
Yeah.
So
totally. Well, how about you? Anything you've been thinking of in addiction medicine news?
I've been thinking of RFK Jr. So in addition, this is an article about, it says, will RFK Jr.'s push for psychedelic therapy help or hamper the emerging field? This is from July 2025. And so it's pretty interesting. In some regards, it's very positive that we have like someone in recovery in a position of power, right? So I think it is kind of amazing that someone got better, that they're committed to still going to their AA meetings, and that they've overcome their substance use, and now they're like the head of a major branch of our government. But it's really interesting how like someone with that background has kind of shaken up everything, right? I think we've talked about before, there's been open critique of a lot of our conventional treatment strategies. So medication assisted treatment. It's funny, he's talked poorly about that. And then other times when he's in an environment where that's not very well received, he's kind of backed off on it and been very nebulous about. But now his new push for treatment is psychedelics. So we're now pushing psychedelics. And so basically he is making a promise and advocating for in 12 months that there will be legalization of psychedelic therapy. And this has like a mix of optimism and concern, kind of rightfully so. Yeah, so I think everyone's really surprised about this timeline. Kind of accelerating it to 12 months seems really surprising. It's
Well, I
interesting.
mean, not to interrupt you, but he doesn't know anything about science. Like he also said he was going to cure autism in 12 months. And he's already like 8 months into the year. So haven't heard about that yet.
It's interesting in terms of political support. Actually, it's bipartisan support is actually growing, and a lot of the Republican figures are backing this off of push from the veterans group who feel that psychedelic research would kind of benefit veterans suffering from PTSD and kind of a variety of battle related conditions. Previously, the FDA rejected MDMA for PTSD due to flawed data, and under the FDA's new leadership, they are actually going to revisit what they previously rejected as a top priority. Interestingly, people don't trust medicine or healthcare or the FDA, so we now have a new FDA program which dramatically shortens approval, and so this likely will go through much quicker than it previously would have gone through in previous administrations. There is a lot of concern about kind of risk for bypassing some of this rigorous scientific research and, early adoption and kind of release of this endangering patients. But it's something we're currently balancing. Like I stated, a lot of this is driven, at least from the Republican side, about feelings that kind of many veterans have felt that the product has been life-changing and helped them with their PTSD and other kind of battle-related issues and also addiction. I guess we'll have to see where that leads us to. I just think it's an interesting top priority, and I'm not sure if it's going to pan out to be as successful as I think people are hoping. But I guess stay tuned.
Well, right. I mean, just the selection bias and all this is so great. It's people who've had positive experiences with psychedelics are the ones who agree to be in these studies and who advocate for them. People who use psychedelics and had harm, I think, are much less likely to put themselves out there. But yeah, I know quite a few people who've had serious, if not irreparable, harm from psychedelics. So it's not all just, fun times. So are you ready to hear about this article?
Yeah, let's do it.
This article is very positive, and actually this article was sent to me by an astute reader, David Rope. He emailed us a copy of this article and asked if we'd present it. And David, if you're listening, let us know what you think of our take on it. I appreciate the tip. So it was called Efficacy and Safety of Varenicline and Bupropion in Combination and Alone for Alcohol Use Disorder, a randomized, double-blind, placebo-controlled, multi-center trial. So it's got all the adjectives. First, a little bit of background. As we know, alcohol use disorder causes an enormous burden of disease worldwide. There's a theory that people with alcohol use disorder have low dopamine, and giving dopamine-enhancing medications might help replace the positive alcohol effects and help people with their cravings and their withdrawals. And most of our treatments, as we said before, for alcohol use disorder are really only partially effective. And there's a real need for additional medications to help, especially for patients who also have opioid use disorder, because one of the key treatments for alcohol use disorder is naltrexone. And if you're on buprenorphine or methadone, of course, you can't take naltrexone. So there's 2 positive studies on varenicline in a subpopulation of people with alcohol use disorder who are in a smoking cessation trial. And there's a study on varenicline plus naltrexone in that same subpopulation. But those are the only 2 studies of varenicline and alcohol use disorder, and they didn't really use any objective biomarkers as the primary outcome. And so this study looked at varenicline plus bupropion, and it's the first study to look at this combination. So John, have you ever used varenicline or varenicline plus bupropion for alcohol use disorder?
Not specifically for alcohol use disorder. I'm sure I've used that combination for people with alcohol use disorder for other things, but not as a primary treatment option.
Yeah, I haven't either. I've used it for smoking cessation. If varenicline doesn't work or the patient, hasn't had good luck with it in the past, I use varenicline plus bupropion plus nicotine. I'll just use all the things to try to help people quit smoking. But I've never used it purely for alcohol use disorder. So let's talk about the clinical question. To sum it up in a nutshell, in adults with moderate or severe alcohol use disorder and recent heavy alcohol use, does the use of varenicline 1 milligram twice a day and bupropion 150 milligrams twice a day, either combined or individually, reduce alcohol consumption compared to placebo over 12 weeks? It was a 12-week study. Very simple question, easy to understand. The people in this study were adults aged 25 to 70 with moderate to severe alcohol use disorder, drinking heavily at initiation of the study, at enrollment of the study, and during the 3 months prior. So they had to have at least 2 heavy drinking days per week. They were not receiving treatment for alcohol use disorder in the previous 3 months. And of course, it was safe for them to be in the study. The study enrolled 384 people, so pretty big. It was done over COVID between 2019 and 2022, so that did disrupt things a little bit. 72% men with a mean age of 57. So older men, older middle-aged men in Sweden. This was on outpatient clinics, and these were heavy drinkers. 75% of their days were heavy drinking days, with an average blood phosphatidylethanol concentration of 1.2. So this is a biomarker that's formed in the presence of alcohol, and it can be detected in blood up to 4 to 6 weeks after alcohol consumption. Its levels correlate pretty well with the amount of alcohol consumed over the previous 2 to 3 weeks. So it's used as an objective biomarker of alcohol consumption. So in this study with the blood phosphatidylethanol concentration of 1.2, that corresponds to about 7.5 drinks per day on average. So that's pretty heavy drinking. 49% were smokers, and about 20% had a hereditary alcohol use disorder. So this is a population heavy drinking, older, middle-aged Swedish men. The intervention was that after a 1-week titration period, they either got varenicline, 1 milligram twice a day, and bupropion, 150 milligrams twice a day. That was the main intervention. And they compared it to groups that were varenicline plus placebo, varenicline plus placebo, bupropion plus placebo, or placebo plus placebo. So there were 4 groups. The primary outcome was this blood PEth, the phosphatidylethanol level, self-reported heavy drinking days, and there were some secondary outcomes like grams of alcohol consumed, self-reported alcohol consumed, abstinent days, craving scores, stuff like that. And it was done over 12 weeks. So John, what did you think of the clinical question?
I mean, I think that was kind of like a lot of our typical kind of alcohol-related outcomes in terms of kind of how much alcohol consumed, self-reported days. I like the objective biomarkers. I feel like that's always kind of a nice addition for this.
Yeah, totally. So I think this was a valid trial. It had a lot of strengths. It was randomized into 4 treatment arms, double-blinded, placebo-controlled. They did good statistics. I thought it was appropriate. They corrected for the multiple outcomes. Subgroups and sensitivity analyses were all pre-specified. The groups were randomized. I won't say correctly. They were randomized, and all groups were similar at the start of the trial. All groups received equal interventions for the blinded placebo. The sample size was large enough. They did meet their sample size calculation. And when they were trying to figure out how many patients to enroll, they took the high dropout rate into account that's inherent with addiction studies. They had good outcomes, like you said, both objective and subjective outcomes. And they did an intention to treat analysis. They also reported adverse events, which was important in this study because this is a new treatment. There were some limitations, though. About 120 people did not complete the full protocol. 12 weeks is kind of short. It's like, what happens after that? So definitely a weakness in this study. And then I don't know if funding would cause bias, but the primary authors of this study own a pharmaceutical company that produces the combo medication tested, which I guess could lead to bias. But the funders, both the research institutions and the government agencies and the author's own pharmaceutical company, those funders, it said, did not contribute to the design or implementation of the study, although it's hard to say what that means if the owners of the company that funded it are the authors of the study. So, it could cause bias, but honestly, since these are 2 easily available generic medications, you don't have to use the author's special combo pill to get the effect. So what did you think? Did you think this was a valid trial?
Yeah, I mean, I kind of disagree a little bit about 12 weeks being too short. I feel like sometimes for alcohol use disorder, it's such a cyclical thing. I feel like a lot of people that can even break that cycle for a period of time can sometimes kind of take over on their own. So, I mean, I think it's not an invalid time point whatsoever.
Well, right. And I think because, this is a difference between alcohol and opioid use disorder. I don't see my patients with alcohol use disorder taking medication long term. Like I'll offer it long term, but honestly, yeah, after a few months, people are mostly not interested in coming back for any more medication. So maybe it mirrors clinical practice. So let's talk about the results. I have to admit, I did struggle a little bit, and you took all the statistics classes, so maybe you can offer some insight here. But I struggled a little bit to turn the data in the charts and graphs into something I could kind of understand clinically. But that might be me, not the paper. So starting with the primary outcome, basically they reported not like raw numbers or number of drinks or anything that you would expect. They reported the coefficient estimates and the Cohen's d effect size. And if you don't know what those are, which I wouldn't expect because I didn't know what those were either, basically they both measured the size of the difference between two things and how statistically significant, how likely that difference is. So the larger the values, the larger and more statistically significant the difference between two groups are. So it's a measure of kind of amount of difference, not so much difference in the actual alcohol consumed. So they did show that there's a statistically significant difference between varenicline and bupropion and placebo, and varenicline placebo versus placebo. So really the varenicline is the med that seems to make the difference here in our primary outcome, which is alcohol consumed, as represented by blood phosphatoethanol levels. So the same effects were seen in the per protocol analysis and the regular intention to treat analysis. The other thing that was really interesting, and I'll get to that, is about the adverse effects. So I'll get to that in a second.
So was this like in the appendix, the raw data? Like, I understand what you're saying. I feel like, and I'm not kind of making any inferences here, but the fact that we don't have raw numbers, and then this makes it more difficult to understand. I feel like it, sometimes that does say something, right?
Right. It's like, why don't we have the raw numbers? Yeah, we don't really I had downloaded all of like the supplemental information that went along with this study. And they presented other different charts that were also not easy to understand. So it didn't help. They presented more charts and they weren't helpful to me. So I kind of had to try to figure it out on my own.
I think you're going to get an email explanation on this one from an author.
I would love it. Those of you who wrote this paper, please email me. And what I'm interested, okay, if you wrote this paper and you're listening, please email me. So I tried to kind of reverse engineer the statistics to make the conclusions clinical, but please check my calculations, authors, and let me know if I did it right. So when I tried to reverse engineer these numbers, basically here's what I got. The authors showed that varenicline and bupropion reduced alcohol consumption by 3 drinks a day from a baseline of 7.5 drinks a day. So that's pretty good. Like, close to half. Placebo reduced alcohol use by about 1.5 drinks a day from a baseline of 7.5. So just being in the study and taking placebo did reduce your alcohol consumption a little bit. Taking the varenicline plus bupropion reduced by, from 7.5 drinks to 3 drinks a day on average. And the improvement was even a little greater in the per protocol analysis. So that was my conclusion. I want to talk about the adverse effects because that's important in this study also. They did a really good job of reporting the adverse outcomes. The only 2 outcomes that were different between varenicline, bupropion, and placebo were nausea and fatigue. And you and I have talked about side effects from varenicline in the past. People worry a lot about abnormal dreams, but there were more abnormal dreams in this study in the varenicline group compared to placebo groups, but it wasn't statistically significant. It wasn't a huge difference. But there was a lot more nausea and fatigue with varenicline. But when you took bupropion, that attenuated that nausea and fatigue, and especially fatigue. The varenicline plus bupropion had less fatigue even than the placebo. And in terms of nausea, also about 61% of patients who were taking just varenicline had nausea. If you added the bupropion in, it went down to 38%. So it really helped with that nausea. Bottom line, will these results help me in patient care? And I think they will. Other than being Swedish, my patients are similar to those in this study. Over 12 weeks, it reduced the alcohol consumed, which is the primary outcome. And that's what my patients would want because that's why they come for treatment with alcohol use disorder. Longer term data would be nice. And not just because I think 12 weeks is too short, but if you look at the graph, John, that you can't really see the graph because you're listening, but the alcohol use goes down at like week 7, 8, and then it starts to go back up again, like week 8, 9, 10. So the effect, the primary effect that you see seems to be kind of going away again as the weeks went on in this study. So
Yeah.
I don't know.
Interesting. Yeah, I'm looking at the graph.
So I would wonder if they kept it going for 12 more weeks, would patients go back to baseline? And I'm not surprised because any behavior intervention, like when you first start it, people are more enthusiastic and then they kind of lose steam for it as time goes on. It's not sustainable. So,
yeah.
But these medications are commonly used in my treatment setting. They're easy to prescribe. There were no serious adverse effects. I think the benefits are worth the costs. And Varenicline really had the strongest effect. So it could be used as monotherapy. Definitely, like adding the bupropion helped with the side effects, but the Varenicline alone could be used. And so if you can take Varenicline and bupropion, I definitely will offer this combination to my patients for alcohol use disorder. It'll be really useful for patients who smoke and patients who are on opioids like buprenorphine. So I actually really plan to add this to my arsenal for the next person it seems relevant for. I haven't gotten a chance to use it yet, but I definitely plan to. What about you?
Yeah, I'm definitely going to file this one away as a possibility in the future. I feel like you have such limited options, right? And I feel like too, you're right. So many of these other substance use disorders often involve an opioid use disorder. And when using a partial or full agonist, right, you lose all of your treatment options here that have a lot of evidence behind them. So I'm always looking for something new. I think this could have a niche.
Yeah. Yeah.
I'd like to see more trials going forward with like longer term effect, but I think from this one alone, it's worth a try.
Yeah, for sure.
All right. Well, thanks for presenting that. All right. Talk back. We got a comment from listener Harmis Rad on episode 63 about maternal buprenorphine dose and NALS. Great episode and topic. Thank you. I wanted to add that methadone dose hasn't been conclusively linked to increased severity or duration of NALS. In my experience treating pregnant patients on methadone, many delivered healthy babies with minimal withdrawal. I believe severity is likely tied to tolerance, especially with fentanyl exposure, which often requires higher opioid agonist doses. Interestingly, breastfeeding may offer mild relief via trace methadone in the milk, though not clinically significant. The article in your episode demonstrates association, not causation. I believe higher doses reflect higher maternal tolerance and consequently neonatal tolerance. In such cases, lower opioid agonists may not reduce NALS and could increase relapse risk. For reference, see ACOG's committee opinion. And then that was cited, which found no significant link between methadone dose and NAS severity.
Right, and I'll take that correction. You know, I had said in that episode that there was a link between methadone dose and NAS severity. So I'll take that as a correction. I guess the question is, how do we sort out tolerance versus dose? Because the two kind of seem to come together, but maybe not. I don't know. Like my patients on buprenorphine, it's sometimes a little bit idiosyncratic what dose people need. You know, some people need really high doses, some people don't. And it doesn't always correlate with what kind of opioids they were taking prior to starting treatment.
Yeah, definitely. Well, thank you for that. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. Have your opinions about the articles included in a future episode? Send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. CME support from MyCare is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employer or the author of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.